Should we go ahead?
So there's 25, 26. I request all of you to switch on the video once actually for a few seconds, 2 seconds. I'll take a photo for enough record. Yeah, thank you. Perfect. Thank you. So good evening and welcome all of you to the NOEL session. This session, as we all are aware, last 4 years. Sir, good evening, sir. Ashish, sir, good evening. Just about to start. You are in right time. Unmute, please unmute yourself, sir. Unmute yourself.
You are muted, sir.
Dr. Sweta, video just 1 second. Dr. Sweta, video for 1 second.
सर आप म्यूट पे है सर. आशीष सर.
Hi, sir.
Please unmute, sir, yourself. Ashish, sir.
Hi.
Hi, sir. Welcome to NOEL session.
Yes, sir.
So we'll start the session. Already 70 students joined. So we can start now the session. So welcome all of you to the NOEL session. As we are aware, last consecutive 4 years, we are running the NOEL session for an online education training for NRF trainees. This is the 4th edition this year. And the session number 6, and very interesting case, which is really challenging the neonatologist, for a neonatologist who deals with the critical newborns, sick newborns. The primary pulmonary hypertension, radiopathic hypertension, always a real challenge to manage. So today's case, there's Dr. Bhavya Patel, NNF trainee from the Urban Newborn Care Center, Ahmedabad. He is going to present a case, a bedside case, through which we will learn how to manage, optimize the management of PPHN, and to moderate the session, Dr. Renowned neonatologist Dr. Ashish Mehta, Director and Consultant Neonatologist from Orphan Newborn Care Hospital. He is there to moderate the session and to ably give us the inputs and guide through the session, and to complement the session and supplement with the knowledge inputs. Today, the newborn specialist Dr. Jaikishan Mittal, neonatologist, Director of Neo Clinic, Jaipur. He is available to carry, there's a lead faculty to carry the discussion throughout the session. Along with that, I invite Dr. Sweta Vakru. She is one of the lead pediatric cardiologists, Rainbow Children Hospital Cardiac Center. She is there with us to give the inputs about the different cardiac perspectives of a PPHN management, the diagnosis, and other inputs during management, how to optimize the care. Along with this faculty, leading faculties, Dr. Bijanand, my dear colleague, he is available. His interest is point of care cardiac assessment, simulation. He is there to give us inputs during the management, case management. So with all the inputs, probably in next 40 or 45 minutes, throughout the presentation, we will learn how to optimize management of a sick PPHN case in the NICU. With that, this session, I will invite Dr. Bhavya to go ahead with the presentation. And throughout the session, I invite the faculties and the students all to interact and put the questions in the chat box. For all the trainees, they can put the questions in the chat box, which we'll take later at the end of the session. So thanking the moderator, Dr. Ashish Mehta sir, and his team, I will just invite Dr. Bhavya to go ahead with the presentation.
Very good evening to all respected teachers. Myself, Dr. Bhavya Patel, going to present PPHN case under guidance of Dr. Ashish Mehta. Presenting a case of male neonate of baby of XYZ, 39 plus 5 weeker LSCS delivered baby, 3.25 kg was birth weight. Baby was referred to our NICU on 8th day of life in view of the PPHN with ventricular dysfunction. In antenatal history, the mother is 23-year-old, primary mother. Pregnancy was diagnosed with urinary pregnancy test at the 1.5 month of the amenorrhea. Pre-pregnancy weight was 52 kg of mother. Mother blood group was AB positive. First trimester history. Mother was booked case at private hospital, and the regular antenatal visit at monthly intervals was taken by the mother. She tested negative for the HIV, HBsAg, and VDRL. Folic acid was taken regularly. First trimester scan was normal. There was no history of fever, race, lymphadenopathy, drugs, or radiation exposure. During the second trimester, both iron and calcium tablets were taken regularly. First dose of TD was taken at 16 weeks of gestation, and the second dose of TD was taken at 24 weeks of gestation age. A USG scan was done at 20 weeks of gestation, which was normal. During the third trimester, antenatal visits were taken every 15 days at the nearby private hospital, and the mother weight was increased to 63 kg. Third trimester USG scan and doctor was done, which was the normal. No history of fever, burning, micturition, conversion, false smelling, liquor, leaking or bleeding PV was there. Postnatal history, as per we receive in the referral note, baby was LSCS delivered, cry immediately after birth, had the meconium stain liquor. Baby required the surfactant therapy, conventional ventilation, followed by HFOV, IV fluids, IV antibiotics, milrinol and sildenafil at the referring NICU. On receiving at 8th day of life in our NICU, temperature on receiving was 36.2 degrees Celsius, heart rate was 172 per minute. Baby was kept on the HFOV ventilation. CRT was less than 2 seconds. SpO2 preductal and postductal was 84 and 74% respectively. Pulses was well palpable in the all four limbs. RBS as admission was 80 for Mike. Invasive BP was showing the 68/37 with mean BP of 48 by mmHg. During
Dr. Bhaga can go to next previous slide. So I will request, till now actually we got the history of the baby and the admission few details. I will request both the faculties, all three faculties, just to little bit initiate the discussion, to start the discussion how to, when we get this type of babies, what to, a bedside clinician, how to proceed and what to think of. Then probably Dr. Bhaga will guide when they examine the baby and manage what challenges later. So all the faculties, including moderator Ashish sir, I'll just request to give a few inputs with this information, how to think, a student, a trainee, a bedside clinician, what to think and how to start his thought process, how to go.
See, basically, this is going to be a very sick baby. If you look at this, that baby you are receiving at 7 day of life, full-term baby. And first of all, why this baby develops surfactant? Why did we receive surfactant? We understand that when the full-term baby receives surfactant, that means the lung disease must be very bad. And because of that, everything was tried and nothing was, I mean, the saturation was not possible. That might be the reason of surfactant therapy in this particular baby. So when you tend to get this history, we need to get into detail that why this baby requires surfactant, first of all. And then you are looking at the respiratory support, the HFOV. So we need to understand that which kind of setting were there, how much FiO2, how much the pressures, what was the other settings on HFOV. And baby was on 2 inotropes in form of one pulmonary vasodilator and one inotrope, milrinone and the sildenafil. So what was the picture in last 7 days? That I would like to know when I received this kind of babies. What was the, whether blood gases were done or not? What was the chest X-ray? What was the other parameters like septic parameters? All this history will be required when you take this baby to the NICU. And on receiving, obviously, my priority would be to keep the things right. The temperature, sugar, pulse of oxygenation, and intravenous fluids and all that. That is what is required at the time of admission. Minimal support, minimal requirement.
Yeah, so Dr. Bhavya, so you are you have received a baby with the persistent pulmonary hypertension.
Yes,
now, as we all know that in these kind of the scenario, PPHN is a complication of the basic disease process. As Dr. Ashish Mehta has already said that baby was very sick, required surfactant and a higher amount of ventilation and some amount of cardiac support. So we need to know what is the basic respiratory diagnosis which have led to PPHN. So is there any clue so far, or what was the diagnosis at the referring center?
Definitely, sir. There was the meconium stain liquor as well as they have given the surfactant. So probably this is the secondary PPHN due to meconium aspiration syndrome, which have required the ventilation, even HFOB, and might be there was the hospital acquired infection or sepsis, which can worsen this PPHN more. So that's why they have given the IV antibiotics and all. For the similar, almost 100% FFO requirement was that. That's why they have chosen to refer the baby, so we can further manage the baby.
Very good. I mean, and since this baby developed PPHN, we should also look at this point of the time whether there were any other risk factors available in our history and examination. So, what kind of other risk factor we should look when a baby is having pulmonary hypertension?
With pulmonary hypertension, we should also exclude some intrauterine hypoxic insert was there or not.
Very good.
Like we should look for the third trimester scan and all where any Doppler abnormality was there or not. This kind of the intrauterine thing. During the transition period, like at the delivery room, we should also assess that history. There was soft transition present or not. Like if baby was having the perinatal asphyxia event at the birth, or having the TTN or anything which prevent the soft transition from the fetal to the neonatal transition of the circulation. So this kind of risk factor we should also ask for, so we can figure out this is idiopathic PPHN or the secondary PPHN pertaining to some specific cause or not.
Yeah. So as you said, it's a case of meconium aspiration syndrome. So we know that almost 50% of the meconium aspiration syndromes are usually associated with some or other kind of perinatal asphyxia. So there should be a clear history regarding resuscitation required. What kind of resuscitation was there? Was there any kind of blood gas available in first half hour of life, or cold blood gas available or not, so that we are able to judge whether this was a significant antenatal hypoxemia or not. Then there are certain other antenatal risk factors which we also should elaborate, like diabetic mother or mother taking NSAIDs,
IUGR babies.
IUCR babies. Yeah.
Dr. Bhave, quick question to you.
Yes.
When you receive the baby, as we receiving baby, we got a clear history. One of our colleague, who is a neonatologist or pediatrician, they have treated the sick babies with surfactant and HFO. So what you will think of, what are the term babies, term RDS conditions where the surfactant is really needed? So you have to ask those histories, but what you thought of? Somebody you think the rightly only given. We are not thinking here it is wrongly given, it is rightly given. So term or late preterm baby requiring a surfactant. What are the possible causes? Already discussed, but for the understanding of all the trainees, I will again ask to highlight what are the morbidities where you will think of giving surfactant in a term baby. Preterm RDS we know, leave apart that. What are the term conditions where we can use surfactant?
Apart from meconium aspiration syndrome, some other cause like the congenital surfactant deficiency disorders, as well as surfactant washout due to sepsis or pneumonia can also lead to this kind of picture. So in the full term, which is less likely to require surfactant, but this kind of condition like congenital deficiency and all can lead to this kind of scenario requiring the surfactant within the first initial hours of management.
So these are the right causes. Probably you have enumerated primary hypertension as such primary, or secondary causes like meconium, hypoxia, the sepsis. Those all things may be responsible for the secondary deactivation where surfactant required. With this, actually, I will request Dr. Sweta, a baby who born outside, but there's somebody diagnosed PPHN, maybe hypoxemia, cyanosis, respiratory distress. This all components, mixed components are there. As a cardiologist, so what you will think of a PPHN clinical case is sitting there. We don't know with the evaluation completely, we don't know how to evaluate, optimize the evaluation, how to suspect it PPHN. Whenever it comes to clinical scenario PPHN, what other disease we have to think of. When it is coming to us, how to prepare ourselves. Just to guide for the
That's a very, very pertinent question, Dr. Nalinikan. And actually, I was about to ask Dr. Bhavesh that what is the diseases which can mimic like PPHN in a term child? And because he has tried absolutely everything, he tried surfactant, given milrinone, given sildenafil. So would you still think that it is a primary PPHN, or there can be a cardiac condition which is mimicking like PPHN, but it is a cardiac problem which is actually deteriorating child? Is it possible?
Yes, ma'am. Is it there is a sure possibility we should look for the obstructive TAPVC, one of the
Yes.
DT, as well as some left-sided like HLHS and all aortic stenosis, kind of some systemic duct-dependent circulation can also be present with that. For that, we should absolutely go for the structural 2D echo. That can also mimic the similar scenario as
Bhavya, we
well.
lost you.
The obstructive TAPVR would actually just mimic like PPHN. The X-ray would like very bad and will not responsive to any of the conventional therapy like milrinone, sildenafil. The most important point here is to identify the left-sided obstructive disease, like you have rightly mentioned, like duct-dependent systemic circulation, like HLHS or interrupted aortic arch and coarctation of aorta. So what would happen in that if we try to reduce the systemic flow by giving milrinone or by giving sildenafil, the desaturation would be more and more. And the fact here is the upper limb saturation is also not maintaining. That means either there is an intracardiac shunting which is happening at the foramen ovale level, or there is a possibility that there is a TAPVR, and that's where just there is a mixing happening somewhere, and the deoxygenated blood is going into the systemic circulation. In spite of all the adequate therapy, like very high-end therapy is already given. So we have to think towards the cardiac condition as well here. X-ray and blood gas would be very much helpful. If it is an infracardiac obstructive TAPVR, which comes, the vertical vein would enter somewhere around the portal vein or your ductus venosus, the umbilical venous saturation will be very high. So that sample will show the saturation more than 90%, but everywhere else your blood gas will show the saturation which is very low. So probably that blood gas is very much suggestive bedside that it is an infracardiac obstructive TAPVR, apart from X-ray and the diagnostic 2D echocardiogram. Hello?
Yeah, it's audible. Clearly, we can hear you. So it's a
Okay.
clarifying thing. So we can proceed the next level of what the clinical scenario Dr. Bhabya can present.
Nalini,
Unless
I just
the-
want to add to this that baby was already an HFOV. This is a very, very tricky transfer.
Yeah.
And would expect that baby would have deteriorated during transport also. So keeping this baby's lung immediately open will be a major responsibility for the attending person or attending doctor.
So, sir, can you highlight actually how you transported, because of sildenafil is there, milrinone there, HFO there, already treated, when really these are challenging.
We transported the conventional
Uh,
ventilation. We just put in higher pressures and we try to see whether baby is maintaining or not. Luckily, baby could maintain, and that's why we could transport this baby. Because so far we do not have HFE in transport, and that's why when we went, we were a bit skeptical whether we'll able to transport this baby or not. Luckily, baby could manage to stay with reasonably good saturation, 85% upper limb, and we decided okay, we can transfer. The place from where baby was transferred was just 1.5 hour away from my place. So not a very long distance to transfer. And we intimated one NICU on the way that if required, I need to come there. If baby deteriorates during transport, I need to, rather than coming to Ahmedabad, I need to go to Anand or other Nadiad place where I can again stabilize the baby and again transport. That was the arranged. That is how it was arranged.
So in these kind of sick babies, I think transportation is a very delicate and important area where baby can deteriorate rapidly, especially in PPHN babies who are very labile. So
Yeah.
momentarily hypoxemia can lead to downhill of the course. So a very well planned transportation and involving your colleagues on the route is, I think, the best way we can transport these babies. Yeah, so We can proceed
very
further.
pertinent point. Both of you highlighted a very pertinent point. If it is a long distance, at 1.5 hours in road, sometimes 2 to 3 hours in on the way, some tertiary level ICU there, involving them probably sometimes rescuers.
Yeah.
Very pertinent point. So this is same experience I said many times also when we transport PPHN sick babies, sick refractory hypoxemic babies. The referring doctor already tried all the things. And sick baby with metabolic acidosis, hypoxemia, really challenging. Now when we are the nitric oxide is accessible to us on the way, when we know the 2D echo diagnosis, you excluded congenital heart disease in those conditions. When we started, few of the cases when we reached by time we reached to hospital, babies are much stabler. But that's the availability of nitric on the road is not a very common scenario in India. But whenever available, things become stabilized. But really, it's challenging for a sick PPHN, which is sometimes deteriorates on the NICU also. When we loud sound, bright light, touch, procedure, that's also sometimes the baby deteriorates on the way on the road transport. 1.5 hours or 2 hours, really challenging to optimize the care during on the way. The neonatology team which transports, they only will realize how many times the fluctuation flip-flop mechanism, how much time hypoxemia happens. But throughout, we have to manage all the hemodynamics, oxygenation, stability. Then you will get the baby to the ICU. That's the real challenge. Yeah. Getting the baby or the evaluation remains there. So we'll go to the case NICU, how we saw the baby. This is the basic detail. Dr. Bhabia will go to the case scenario on the NICU. Detailing.
Yes, on the 8th day of life on receiving gas, we talk the temperature was 36.2 degrees Celsius, heart rate was 172, CFT was normal. There was the preductal and postductal difference was definitely present on receiving 84% preductal, 74% postductal, on 100% HFOV was saturation. Invasive BP monitoring was done, which was 68/37 with mean BP of 48 of mmHg was there. On the first day of receiving at 8th day of life, we have kept the baby on the mechanical ventilator HFOV with this setting of the FiO200 map was 16 and the amplitude was 30 with frequency 8 hertz. Blood investigation as per routine protocol, we have taken out IV fluid with calcium was started. The antibiotic was the meropenem, colistin, tigecycline was continued. The first ABG on admission on receiving was suggestive of the respiratory acidosis with pH of 7.5, PCO2 54, PO2 was 57, HCO3 was 22.4, and base excess was minus 4.7. Considering this oxygenation index was 28, which was more than 25. Blood report was taken. CBC was almost within normal range, with CRP was on the higher side, 28.5 mg per dl. Considering this one, chest X-ray was also done. As per seen, there was the fluffy opacity seen bilaterally in the both lung. Might be seen the suggestive of the changes of the meconeme aspiration syndrome. Considering the OIU of more than 25 as well as 100% FiO2 requirement on HFOV, we have started inhaled nitrous oxide on receiving only at 20 ppm as per the routine protocol. Injectable milrinone at 0.2 mic and injectable adrenaline at 0.1 was continued. For the sedation, we have started with the injectable fentanyl at 1 mic. After starting this, as per the protocol, FiO2 was tapered 5% every 2 hourly. 2D echo was done by cardiologist, which was suggestive of the PPHN with right ventricular hypertrophy was present. After starting the inhaled nitrous oxide, we have repeated ABG at the 4th hour of life, which was suggestive of the pH 7.29 with PO2 was improved to 129. PCO2 was 41, HCO3 was 19.2, and considering this oxygenation index was improved to the 8.9. Vitals at the 4th hour of life, there was the SpO2 improved with preductal was 93 and the postductal was 85. The difference was also decreased and the invasive BP was suggestive of 62/32/49. At 4th hour of life, we have tapered inhaled nitrous to the 10 ppm. On the 9th day of life, at the 2nd day of admission, considering the decreasing the inhaled nitrous requirement as well as considering vital parameter, FiO2 was gradually tapered to 50%. After tapering to the 10 ppm of the inhaled nitrous oxide, we have done the one ABG analysis, which was suggestive of the pH 7.3, PO2 was 134, PCO2 was 39, and the bicarb was 19. Considering this oxygenation index was 7.1. Vitals, after the inhaled nitric oxide, we are tapering. The pre-ductal SpO2 was 94, post-ductal was 88, and invasive BP was also normal. Considering this, with the similar management, IV milrinone at 0.2 and IV adrenaline at 0.1 continued. Considering the tapering inhaled nitrous oxide for the soft transition, we have started tablet sildenafil as well. On the 10th and 11th day of life, the inhaled nitrous oxide was continued at the 10 ppm, as there was FiO2 requirement was between the 50 to 55. So HFOV was continued, and the similar management continued. Adrenaline was continued at 0.1, and the injectable milrinone was omitted. The ABG analysis was done on that day was also 7.4368 PO2, PCO2 was 33, and oxygenation index was 8.2. At the 12th day of life, we were able to taper the FiO2, as well as we have gradually tapered and omit the inhaled nitrous oxide on the 13th day of life. Before doing this, we have done the one blood gas analysis, considering is there any ventilation perfusion mismatch or not, which was normal, with the oxygenation index improved to the 5.9. Along with this, invasive BP monitoring was also normal, so injectable adrenaline was also omitted. At the 14th and 15th day of life, considering all the parameter improving oxygenation index, clinical condition, as well as the clinical scenario has improved, we have changed over to the conventional mode of SIPPV mode, with FiO2 requirement around 25% PIP and PIP 16/5. And after winning, after the 2 hours of the winning, as per the protocol, we have done the ABG, which was also showing the good ventilation perfusion. 7.44 was pH, PO2 was 66, PCO2 was 32, bicap was 21.5. So considering this, we have continued management for 48 hours of life, as FiO2 and the pressure requirements was decreased. Baby was extubated on the HHFNC on the 16th day of life, with FiO2 around 25-30 was required, with flow of 8. One ABG was also done after extubating the baby to the HHFNC, which was showing the 7.45 pH, PO2 was 47, PCO2 was 43, backup was 25.5. So after the at least 24 hours of the HHFNC on the 17th day of life, we have omitted HHFNC as well, and intermittent O2 requirement was there. Along with that, there's baby suck, swallow, reflux are good, and doing neurologically well. We have started with the breastfeeding, and on the 20th day of life, there was no residual O2 requirement or anything. Tablet sildenafil omitted as well. As baby was taking feeds well, remain oxygen free, euthermic and euglycemic on the maternal feeding only. We have discharged the baby on the 22nd day of life. This is the scenario where the serial blood gas analysis. So how we have done intervention. Initially, the OI was the high 28. So this is the almost more than 25. So according to protocol, we have started with the inhaled nitrous oxide. And as per previously discussed, how after starting inhaled nitrous oxide, how the recruitment of the pulmonary recruitment improved and the physiology has improved. The OI was decreased to 8.9, and after that, as per we have discussed, the OI has gradually decreased, and on the 16th day of life, we are able to extubate the baby on the HHFNC. On the general examination before discharge.
Yeah. So in this blood gas, in the last slide, in the blood gas slide, there is one important parameter which we have not mentioned at all. What is that?
Sir, arterioregular difference of to ADO2, we should consider in case of PPHN to its severity, and we can know the severity.
Anything else? So lactate is one finding which is very important to indicate hypoxemia at tissue level.
Yes.
So whenever a baby is improving, that will tell you about the oxygenation status at tissue level. So lactate should also be seen and should be mentioned whenever you are mentioning serial blood gas analysis.
Yes.
Right. Next.
Dr. Bhavya, on quick questions in the ABG slide.
Yes.
Just fully not related to the case. I'm seeing the ABG and serial parameters of ABG. The first ABG, the admission ABG, the pH is 7.5, PCO2 is 54, BICAP is 23. So is this an overventilation or some ABG error? The pH we are getting 7.5, 59 or 50, I'm not aware. The ABG is always explained 2 digits. So remaining ABGs are always 7.29, 7.30. But how the pH is 7.5, 59, maybe 50, alkalotic with a PCO2 of 54. So was there error or it is some disease, other concomitant disease process was there with the baby?
That was the on receiving ABG. Considering clinical, we have already starting the management of the baby, but this kind of error can be occur due to the sampling error or some O2 bubble, or was there or any missampling. This can be taken plus that.
So is this ABG are the parameters explainable? So whether this kind of pH is possible with 54 CO2 and 23 bicarb. So first thing is this correct ABG?
See, this is when we receive the baby. So how much bicarb has been pushed over there, that you don't know at the referring center.
Bicarb is not very much, sir. Bicarb is 23.
23.4. We don't know those history. So that because of the bicarb student has gone up, or we don't know whether overzealous bagging has happened or not. We don't know that part. But this might be erroneous also, as you said, it may be erroneous also.
Look like erroneous ABG because
You are
pH,
right.
PCO2 and bicarb are not corroborating.
The renal and liver status was okay examination wise clinical. So I hope that clinical examination of liver, hepatic status and kidney status clinically was probably okay when you received the baby.
Yes. Okay. That was normal.
We'll go through. So one point is clearly highlighted by the ABG trend is there. So just to highlight things when we are talking about PPHN with nitric oxide, is Dr. Mittal told one lactate who will know the tissue oxygenation. And for all the students, trainees here, I will say, when you are writing OI, it gives us a picture, pre-management and post-management, how the improvement happened. And the severity of hypoxemia, the trend at least to know continuously, very well documented here. Along with that, I will request for the training, at least document on ADO2 also. Because OI will talk about oxygenation, but about overall ventilation, overall perfusion and perfusion mismatch, these 2 other parameters to know. If parallelly we will monitor ADO2 along with OI, this will give us a picture, improvement, deterioration, and what is the status. These both things. And if you're using nitric, if there is a facilities there, which is majority of ABG machines nowadays, the ABG machines, the facilities are available. Try to ask and document methemoglobin level when we are treating nitric oxide. That will be my request. When you are looking into ABG, at least ABG doing means by default methemoglobin available many of the centers in the ABG. Ask the question, if we are treating, at least we should know during our treatment of nitric oxide, are we monitoring? Are you aware that the methemoglobin is normal range? That's a few of the things for the training I'm just suggesting here, because very nicely the trend is available with us. The sickness reflecting from the first ABG and improvement, and constantly there is a progressive improvement. That's a very nicely documented. Dr. Bhaga has documented nicely, but few things we can add probably when we are clinically assess the baby. So any further things, Dr. Bhaga, about after this ABG, so that we can go for further discussion.
Dr. Bhagia, it's I mean, really hearty congratulations on managing so well this baby. But would like to know more information on echocardiogram, like what is a foramen ovale shunt, what is the size of ductus arteriosus, what is the amount of like right to left shunt happening, and what is the right ventricular function? Because right ventricular function here predominantly going to determine the cardiac output as well. And acute increase in pulmonary pressures would present with right ventricular dysfunction and would have ventricular dysfunction, the right ventricular dysfunction, and can present with low blood pressure. So, like, do you have those information on echocardiogram here?
Definitely, there was, ma'am. There was a right to left the shunt from the PDA was there with the PO showing the bidirectional shunting. Was that there was the absolutely normal ventricular function at our place, which might be due to patient was received the milrinone from initial transport place. From there to DECO, there was suggestion on the ventricular dysfunction. But at our place, there was the ventricular dysfunction was not there, but right ventricular hypertrophy was definitely there, with bowing of the interventricular septum toward the left side of the ventricle was there. So that
Yeah,
was.
I would like to also emphasize the amount of TR. We feel that if it is a severe TR, it is corroborative of severe pulmonary artery hypertension. But if right ventricular function is normal and it's a competent tricuspid valve, we may still get mild TR with severe pulmonary artery hypertension. So it is very important to assess what is the direction of shunt on the ductus arteriosus level. There are two aspects to look at this. If the ductus arteriosus is large, so right ventricle is decompressing through the ductus arteriosus and descending aorta. So right ventricular function will be preserved for a really long duration of time. But if the ductus is getting gradually constricted and there is a severe PH, so there is no decompression to right ventricle. It cannot go through ductus and the pulmonary artery pressures are very high. Then right ventricular dysfunction will set in and there would be more quantum of TR. So in early stages of PPHN, we may not really have severe TR, but still pulmonary pressures would be very high. So why I was asking about the ductus arteriosus, because if the ductus arteriosus is restrictive and there is a ventricular dysfunction and there is a shock, the systemic blood pressure is low, and you rule out the cardiac problems, then the role of prostaglandin is there. So like you give the prostaglandin, increase the size of ductus arteriosus till you control the PPHN, the cardiac output would be maintained at the cost of cyanosis, but at least perfusion would be maintained and that would behave like a fetal circulation, like how it is there in the fetal life. So that particular subset with presenting with shock, ventricular dysfunction, and there is a PPHN with restricted ductus arteriosus would have role of prostaglandin to maintain the cardiac output till all this oxygenation gets little bit stabilized.
Yeah, and in those scenarios, in fact, INO will not be, I mean, INO is contraindicated because you do not want to push the blood, divert the blood to lungs and have a shock-like condition for a long duration.
Yeah, so I think that on echocardiography, when you discuss with your pediatric cardiologist, we should as well discuss like how is the size of ductus, what is a ventricular function. To start with, it might be preserved, but in a long-standing duration, like it is already 8 days old baby, so it is a little bit longer duration. So there might be set in the ventricular dysfunction. And of course, the milrinone helps here very well. We should also understand the role of adrenaline here because adrenaline acts like a dual edge. We know that it's a vasoconstrictor on systemic circulation, but on higher doses, it is also a vasoconstrictor on pulmonary circulation. So when we go up on adrenaline, higher doses, noradrenaline, so we have to keep in mind that it will also give constriction to pulmonary arteries, pulmonary arterioles. So that acts little bit dual edge SWOT kind of system if we are using this vasopressors. But obviously the milrinone is probably a very good drug here. It acts both pulmonary vasodilation and it also helps in ventricular function.
Any further clinical detail, Dr. Baba, any detail? This is the last slide, the image slide.
The further detail was the just clinical examination which routinely performed, which I am going to discuss. I am examining the baby with the proper aseptic precaution in the servo control warmer on the room bed. Temperature probe was attached to the right lower part of chest. The saturation probe was attached on the right hand. Vital parameter was 36.8 degree. Heart rate was 140 per minute. Peripheral central pulse is well palpable. CFT was 2 seconds. Right upper limb BP was normal. Left lower limb BP was normal. There is no pallor icterus cyanosis or edema was present. anthropometry, which was on the admission parameter, was 3.25 kg was weight, length was 49 centimeter, head sun was 34 centimeter, which was according to intergrowth 21st chart within the 10 to 15 centile, which demonstrated here as well. On the head to toe general examination, there was no swelling over at present. Anterior frontal was 2 by 2 centimeter open at level. Posterior frontal just tip of the finger administered. No facial dysmorphism. Red reflex was bilateral normal. Ear was normal in size, shape, and position. There was no cleft palate, no cleft lip, no any birthmarks or injuries. No septum ala breach appears normal. Neck was no swelling over the neck, no polydactyly or syndactyly. Back and spine was normal, anal opening was present and patent, genitalia was normal, bilateral hip examination was normal as well. On the systemic examination, RS was, there was no septal deviation or block, no pulling of secretion, bilateral symmetrical chest rise, air entry bilateral equal and clear. There was no signs of respiratory distress. Central nervous system was also examined, which was suggest of the normal posture, which spontaneous movement of the all four limb was present as well. For the tone, passive tone was examined by the scarp sign, which was hand does not cross the midline as the baby is the full term, heel to ear maneuver, not touch the ear. Power was more than 3 by 5 in the all four limbs. The cranial examination was also done as a routine, which was normal. Bilateral knee jerk was present +2. Plantar reflex was dorsiflexion of the great toe with extension and the fanning out of the other toes. All primitive neonatal reflex like the palmar plantar grasp present, startle present, routine, and the sucking present. CNS examination was at discharge was definitely important in this kind of case, as considering PPHN we should absolutely look for the neurodevelopment as well. And the CVS examination precordium was normal. Apex impulse was located at fourth intercostal space. First and second heart sound was present. No murmur heard on the auscultation. Per abdomen examination was absolutely normal only. On the summarize the case, the 8-day-old male neonate LSCS delivered from the primary mother with the no significant obstetric antenatal history was referred to us for the management of PPHN with the ventricular dysfunction secondary to MS. With the treatment history at the referring NICU was a surfactant, HFOV antibiotics, IV fluids, sildenafil, Milinon as well. After admission, we have offered the inhaled nitrous oxide for the 5 days, injectable Miliron and adrenaline given. Antibiotics were continued, and the baby was extubated on the HHFNC on the 16th day of life, and the discharge on the 22nd day of life. On putting the diagnosis, there was the single full-term 39 plus 5 weeker, 3.25 kg, appropriate for date, male child, which was LSCS delivered, cry immediately after birth, meconium aspiration syndrome, and the PPHN with ventricular dysfunction requiring surfactant therapy, HFOV, and inhaled nitrate. Going to the basic and all the PPHN management and the etiology in the following flow. Etiology, pathophysiology, discuss some DDs, basic DDs of the hypoxia in the neonate, echo findings, and the management of the PPHN on the glance. The basic etiology, there was divided into the two kind of idiopathic and the secondary PPHN. In the secondary PPHN, which is the mostly 80 to 90% of the PPHN cases we are receiving, the lung parenchymal disease, which will lead to the abnormal constriction of the pulmonary vasculature. The commoner cause like the MS, which we are showing here, pneumonia, sepsis, RDS. The another is the abnormal or the delayed transition at birth, like the baby was having the TTN, which is less likely but can be turns into this perinatal stress, asphyxia, syndromic baby trisomy 21, as the baby having hypotonia, might be low respiratory effort at birth, which can affect the soft transition, as well as associated congenital heart disease can also lead to secondary PPHN. And the third pathophysiology was lung hyperplasia, the hypoplastic pulmonary structure like the in the Porter syndrome or the congenital diaphragmatic hernia, oligohydramnios, which lead to hypoplastic lung structure, and which in turn lead to the PPHN. And other 10 to 20% cases of the PPHN are the idiopathic only. The basic pathophysiology, considering this in the idiopathic or the any pathophysiology, which ultimately lead to this ventilation perfusion mismatch and overall hypoxia and all, which lead to abnormal vascularization and abnormal transition at birth, which ultimately lead to PPHN. Like in the asphyxia and all, the cardiac dysfunction occurs, and the sepsis as well, which turns out into ventilation perfusion mismatch, and ultimately the PPHN picture will be appear. The idiopathic or black lung PPHN, in which ultimately lung parenchyma is quite normal, but there is issue in the lung vasculature. So this reduced pulmonary blood flow can again lead to this whole PPHN physiology. Another parenchymal disease like the MAS, RDS, pneumonia, this ultimately wash out the surfactant. So this again lead to this whole scenario of hypoxia and the vicious cycle of the PPHN hypoxia cycle. And the some congenital diaphragmatic area is also one of the known congenital condition, which due to the alveolar and the vascular hypoplasia lead to this condition. Very few and the rare genetic causes like the ABCA3 gene mutation and the SPINK5 mutation, which leads to Netherton syndrome. These two genetic conditions should be assessed when there was the history of the repeated pregnancy losses, which due to the PPHN or anything, and we have received the baby similar, though we have to once think of this kind of the condition as well. In the differential diagnosis, though hyperoxia is quite obsolete in view of there is the bedside availability of the echograph 2D echo machine. But if the patient there is patient with hypoxia, there can be broadly three possibility. One is the lung disease without PPHN. Second is cyanotic congenital heart disease, as we previously discussed, like duct dependent circulation, obstructed TAPVC and all. And the third is PPHN. In the case like the lung disease without PPHN, there is definitely respiratory distress pattern. In the cyanotic heart disease, there will be definitely tachypnea present, but distress will be not as significant as like the saturation of baby will be very low, but distress was not that proportionate of the saturation. And the in PPHN, it's often present respiratory distress, oxygen saturation on the pulse oximetry. In the lung disease without PPHN, there will be definitely some improvement with supplemental O2, with CCHD. There is very minimal response to supplemental O2, and in the PPHN, there is specifically labile saturation will be there. Hyperoxia test, which is done by after giving 100% O2 for the 10 minutes. After that, we done the PaO2 assessment by arterial blood gas. If it is more than 150 mmHg, then it's probably lung disease without PPHN. In the cyanotic CHD, there will be no PaO2 improvement. It will be remain less than 100 or less than 50 only. And in the PPHN, it will improve, but not as much as the lung disease without PPHN. So ultimately, we can put diagnosis by doing the chest X-ray, and the definitive diagnosis by 2D echo. Like in the cyanotic congenital heart disease, we can go for the 2D echo, and we can know definite what structural defect lead to this kind of the situation. Now coming to the echo findings of the PPHN, there is definitely there was the disproportionately large right side of the heart with the right ventricular hypertrophy on the visual inspection of the simple 4-chamber view as well. For the estimation of the pulmonary artery systolic pressure, we should use the tricuspid gradient. We will discuss this in the next slide as well. The direction of the flow from the patent ductus arteriosus, as ma'am discussed, is also important. Like if there was the right to left shunt through PDA is present, this quite suggests there is the suprasystemic pulmonary artery pressure. If the shunt is left to right, then this suggests there is the subsystemic pulmonary artery pressure. If there is the bidirectional shunt, then this might suggest the pulmonary artery pressure is equals to the systemic blood pressure. The direction of the blood flow across the PFO is often it is bidirectional, which seldom it is right to left as well. The one of the important finding is the flattening of the interventricular septum. This flattening of the IVS is almost proportional to the severity of the PPHN. Assessment of the right ventricle and the left ventricular function is as well very important for the deciding the what should be the management guideline for us. For the assessment of the right ventricular function, we should do the TI index using the tissue Doppler and the tricuspid annular pansystolic excursion. And for the left ventricular inspection, again we can use the TI index using tissue Doppler imaging. This slide, the basic suggest how the 2D echo views basically help us. The first is this basic apical view, which will suggest the how tricuspid regurgitation, as ma'am said, this is a commoner in the PPHN. There will be definitely there. There will be decept of the interventricular septum, right ventricular hypertrophy and dilatation, as seen in this view as well. Definitely there was the end in the long paraaxial views and the short paraaxial views. There is seen this septal deviation toward the left side, which can be seen. This is the Doppler imaging of the patent ductus arteriosus, which is definitely suggesting the right to left shunt in this slide as well. We can use the tricuspid annular pansystolic excursion for the right ventricular function at the level of the tricuspid wall, and the tissue Doppler imaging can also use by TAI indexing, which can know for the right and left ventricular function both. So ultimately, this basic 2D co-finding can lead us to how can we manage with the which kind of inotrope or when to introduce as well. The management part of PPHN will be broadly divided into the medical management using the pulmonary vasodilators and the inotropes, and the important management is ventilatory management as well. The basically as initially discussed, the basic inotropes we can which can introduce is the one of these epinephrine, as ma'am discussed, and the lower dose it affect and the B1 B2 receptor, so it decrease SVR and inotropic effect as well. But at the quite higher dose, it affect the alpha 1 receptor as well, so increase the SVR. Norepinephrine is work on the alpha 1 alpha 2 receptor, so it have the vasopressor effect and the increase the SVR. The milrinone is the inodilator, which effect on the phosphodiesterase 3 inhibitor and the effect on the B1 B2 receptor. So ultimately it is the lusotropic effect, inodilator effect, and increase contractility and the decrease SVR as well. The dobutamine at the 5 to 20 mic effect on the B1 and the B2 receptor, which can lead to inotropic effect as well as decrease SVR and the increased cardiac output. Dopamine at the renal dose of 1 to 2 mic at DA1 and the DA2 dopaminergic receptor, renal and mesenteric dilatation will be there. And the quiet on the cardiac dose at 4 to 20 mic, it have the inotropic and the vasopressor effect. The more important part of the PPHN management will be the inodilators, which specifically the commonly we are using. The first one will be the sildenafil, which is available in the two solution. One is the intravenous and the oral. The phosphodiesterase 5 inhibitor is its mechanism of action. The one of the side effect is it also decreases the SVR. So definitely systemic hypotension should be assessed when we are offering the intravenous sildenafil. There is the few rarely used are the synthetic prostacyclin like the PGI2 iloprost, which is also available in the two kind of the solution. One is aerolized, which is specifically affect as the pulmonary vasodilator, and the intravenous solution, which will affect on the pulmonary as well as systemic vasodilator as well. The similarly prostacyclin I2, which will affect on the pulmonary vasodilation local only.
I would like to explain here that inhaled iloprost, that is synthetic prostacyclins, and the PGI1, they are not actually freely available in India. It needs DGCA approval on patient-to-patient basis. So iloprost right now we are giving to 3 of our patients with idiopathic pulmonary artery hypertension. The advantage of it can work like a aerolized, and it has only local effect. It doesn't cause systemic hypotension. That is its advantage. We have used that couple of times in older children, in selected patient. It has got a role, but its availability is which limits its use in our country right now. So iloprost is very good. The prostacyclin, the problem is that again, it's not freely available. it is a very good drug to reduce the PVR in acute setting. But obviously in newborn and in PPHN, both are less used till now. The mainstay of therapy still remains the sildenafil, milrinone, and inhaled nitric oxide. And ilioprost, because it's inhalational and it is local, if it is available, then it may work very well.
Along this vasodilator, the inhaled nitrous oxide is the one of the unique action. Then this it have the two property of the selective effect and the microselective effect. The selective effect is suggest it only on the pulmonary vasodilator. There is no systemic effect of the inhaled nitrous oxide mostly, and the microselective effect in the sense like it effect on the well recruited or the well ventilated alveoli only. So improve the ventilation perfusion even the better than the other inodilators or the other vasodilators. One thing we should not always that inhaled nitrous oxide to be used only when the left ventricular function is good. Otherwise, it is cause more harm than the benefit. This is the only the individualized approach, but at a glance we can divide the management. If the PPHN the baby with normal ventricular function and the normal blood pressure, we can start with the sildenafil only. If PPHN with ventricular dysfunction, but there is a normal blood pressure, we can start with the milrinone. If the PPHN with normal ventricular function, but there is the low blood pressure and the perfusion affected, we should start with the fluids, IV bolus, and the adrenaline can be started. If the PPHN with ventricular dysfunction along with the low blood pressure is there, we should start with the milrinone adrenaline. Though this is the individualized approach, can change by change according to patient. The ventilation strategy, ultimate aim of the ventilation, there is the quite a gray area where the preductal SpO2 90 to 95, and a few studies suggest we should target 90 to 97%. At least as per unit policy, we are performing 90 to 95% with the target of the PO2 of the 50 to 80%. But however, with this, we should avoid targeting this magical numbers. Like in some cases, in refractory hypoxia, not responding to even the higher supports, we should decrease this target PaO2 to 40 mmHg and the SpO2 to 80% postductal at least. Because ultimately, if we are giving the hyperoxia and hyperventilation, which can ultimately more inactivate the surfactant, increase the PVR, reactive oxygen species can be created, which can inactivate the ENOS activity, nitrous oxide synthetase activity, and as well as increase the phosphodiesterase factor. So ultimately, the hyperventilation and hyperoxia can do more harm instead of doing benefit to the baby. So ultimately, according to lung parenchymal pathology, we can divide the ventilator strategy. If the parenchymal lung disease is present, like the MS, RDS, and pneumonia, as our patient was having, we should target the lung recruitment. Lung recruitment by increasing the MAP, we are giving surfactant therapy. We can provide so the alveoli will recruited well and the inhaled nitric oxide nitrate will work well. And as well as we can increase PIP. If there is the black lung like CDH, lung hypoplasia, and the asphyxia like condition, we can provide the lung protective strategy by providing the volume guaranteed ventilation along with the conventional ventilation. The almost summarizing the management with the along with the gentle ventilation for the PPHN baby, gentle handling is also important. We should avoid the excessive light, even the minor light and sound as well. We should obviously maintain the euthermia, euglycemia. Normal metabolic balances should be managed, obviously. With intravascular volume, we should manage. If required, we can give boluses, even the vasopressor therapy as well. For the specifically for the lung management, for the parenchymal management, if there is situation demands, we should give the surfactant, which improve the alveoli recruitment, and the later on can even we can better out with the ventilation only. So ultimately targeting the permissive hypercapnia and the permissive hypoxia, we can manage the baby. Thank you. Thank you.
Dr. Father, good presentation was the challenge management of challenging case you described, along with summarizing the protocol, at least for all the trainees there were what are the medications and how to optimize the uses. We understood from your presentation. Thanking you. Now I will say all the faculties, they can ask a few of the practical questions. But before going to invite all the faculties, I will ask you basic question, very, very basic question. Already you presented well, Dr. Bhaga. Just a baby came with hypoxia and respiratory distress. How a bedside when you are examining, clues you will discuss, where you will identify it is not a parenchymal lung disease or a heart disease. It's probably we are dealing with idiopathic pulmonary hypertension. You're a clinician, you will do all the investigations later. You will do X-ray, you will do ABG, you will do the 2D echo. But what clues you want to pass to the fellow when discussing clinicians? So how they will suspect, okay, this baby is a hypoxia, maybe of PPHN origin.
Definitely. For the if we are having the only clinical scenarios or the clinical examination, we will definitely look for the systemic examination. In the like the secondary PPHN, there will be definitely signs of the respiratory distress with the specific signs of the. And in the idiopathic PPHN, there will be less respiratory signs will be there. Definitely, there will be respiratory distress with desaturation, preductal and the postductal difference. But from the clinical scenario, from the clinical history, we can evaluate there was no any risk factor involved. This is the classical case of the idiopathic PPHN. Might be the any genetic cause with the black lung PPHN is there. So from the clinical
I got the message. Yes, rather two messages I got it here. In absence of significant respiratory disease or distress, but baby is hypoxic and looking blue and sick. So maybe you will suspect in a differential saturation. You highlighted the differential saturation, the preductal, postductal differential saturation may be a clue for a clinicians. And when you will see the baby during the examination, you will see there is hypoxemia, but there is very labile. Suddenly there is a little improvement and little again deteriorating suddenly in front of you only. So these are the few clinical clues you want to pass. Then again, radiological differential, 2D, co, ABG, all things are there. But I'm just I want to give message actually. When you see the baby, PPH and how to suspect specifically, not a parenchymal lung disease, not a heart disease. If shunt is fixed like a heart disease, it will remain hypoxemic. If a parenchymal lung disease will be there, they will have a significant respiratory symptom, work of breathing, retraction. The Silver Anderson score or Downey score you will do will be very, very high. But if you will see respiratory stable, but severe hypoxemic way. So that's you are not explaining by congenital heart disease. And there is a fluctuation and there is labile things you are seeing difference. Probably these are the few clues to see. And when secondary causes histories are there, the way first initial session you highlighted, the mechanism history there, early onset sepsis history there, secondary surfactant deactivation, then that's a clue probably in the secondary disease. So it's a good that the examination time you can suspect. And another two questions I will ask, then I will ask the faculties also to ask further. We do OI to start treatment for the nitric oxide to start. There is a rule, probably all must be aware, the student rule of 20. I will just ask to highlight what is the rule of 20 when we start nitric oxide and how you will classify. You did a ABG, you calculated OI. So OI high more than 20 needs nitric oxide, you understand. But OI may be 20, OI 40, maybe 60 also. Depending on OI, can you classify the severity of PPHN?
Definitely, sir. As per from the OI, we can definitely classify the OI is the less than 25. It is kind of the mild variety of the PPHN. If the from the 25 to 40, then is the moderate to severe level, and with the more than 40 OI, it is very severe PPHN. From the OI, we can also direct our management. Though this is not available, but for the more than 40 OI, we should definitely go for the ECMO only. For the more than 25, as per we discuss in this patient, we should go for the inhaled nitrous oxide. And for the question in with the rule of 20, the rule of 20 is the we should start inhaled nitrous oxide at the 20 ppm. At the 20 minutes after starting inhaled nitrous oxide, we should take out the one RTA blood gas analysis, and if it shows the more than 20 mmHg of improvement of the PaO2, then it is suggests the baby is the responder to nitrous oxide. If the difference of the improvement is only 10 to 20, then the baby is the partial responder to the nitrate treatment. And if it is improved only less than 10, then baby is non-responder to the inhaled nitrate treatment.
Do you want to throw any light on the pulmonary venous hypertension? We talk about pulmonary arterial hypertension. What is pulmonary venous hypertension?
Pulmonary venous hypertension is ultimately is a like secondary symptom as a complication of the PPH, and it can develop when the pulmonary venous pressure will be very much on the higher side, which ultimately lead to the left ventricular dysfunction due to there is the excessive afterload will be there. So ultimately is kind of the complication to the PPHN, and ultimately lead to left ventricular dysfunction, and on the vicious cycle can lead to the biventricular dysfunction as well.
Or you can say that in a typical case of CDH, where in utero, because of the CDH, the left ventricular dysfunction is already there. And when you give nitric to this baby, you have got already your atrial pressure will be very high. And because of atrial pressure, left ventricular dysfunction will cause more problem, because left ventricular dysfunction is there. There's enough a lot of blood coming to the atrium, and that will cause more problem with the baby's functioning respiratory hemodynamically. So that's pulmonary venous hypertension. Venous part is full because the left ventricle is not functioning. And the treatment will be different. You to improve the LV dysfunction. Priority of the treatment to improve the LV dysfunction in that case, along with your management of the pulmonary hypertension, arterial hypertension.
Dr. Bhavish, if I got it right, it is what do you want to say? The pulmonary artery hypertension would lead to pulmonary venous hypertension?
No, ma'am.
I didn't understand what you said. There is a pulmonary artery hypertension. Then at late stages, it will become pulmonary venous hypertension, is it?
If like in case of the left ventricular dysfunction, if we are giving the inhaled nitrous oxide, then it can worsen the situation with the pulmonary.
The question was, what about pulmonary venous hypertension? So pulmonary venous hypertension is a primary problem, or it is secondary to pulmonary artery hypertension?
It can be the primary problem as well. Pulmonary venous hypertension is
I mean, for clarity's sake, I would like to say that if there is a left ventricular problem, mitral valve problem, or pulmonary vein problem like obstructive TAPVR, if there is a ventricular dysfunction, if there is a mitral atresia, or if there is an obstructive TAPVR, all these three conditions lead to pulmonary venous hypertension. Okay? Because of pulmonary venous hypertension, there will be secondary pulmonary artery hypertension. Okay, so here it is actually a good question that why inhaled nitric oxide should not be given in left-sided diseases. So it should not be given in left-sided diseases because it works locally. Okay, wherever it goes, it is going to dilate your arterioles. Okay, that's what it do. It will dilate your pulmonary arterioles at the distal level. Now, if there is a pulmonary venous hypertension, that arterioles are already under high pressure, there is a capillary hypertension there. On top of that, suppose you dilate them further, it will cause pooling of blood into the pulmonary circulation. Entire blood would enter the pulmonary circulation because it is getting dilated. And already there is a pulmonary venous hypertension. So it causes two problems. One, it causes pooling of blood circulation. Second, it can cause the parenchymal bleed because the blood circulation is suddenly increasing and capillary pressure is already high because of pulmonary venous hypertension. You understand? All of you understanding? So
is it clear? So
yeah, please go ahead.
Yeah, so okay, I saw a message. Can you explain again? So in left-sided diseases, either there is a left ventricular dysfunction or LA pressure is high, there is a mitral atresia, so LA pressure is high. Then what will happen? There is a back pressure to pulmonary veins. Okay, so pulmonary venous pressure is high. So capillary pressures at the lung again is high. that is causing your secondary hypertension. Now, what is happening with inhaled nitric oxide? It is causing arterial dilatation. When it causes dilatation, it will cause more flow to the pulmonary circulation. So the capillaries which are already hypertensive, there is a venous hypertension, there is a capillary hypertension, it is receiving suddenly more blood also. So what will happen with that? It will bleed. It will bleed, and most of the blood is now diverted towards the pulmonary circulation rather than your systemic circulation. So it causes two problems. So it will cause parenchymal bleeding because sudden increase in gush of the blood into the pulmonary circulation, and also it causes pooling of blood. So now is it a little bit clearer? So in left-sided obstructive diseases or left ventricular dysfunction, the inhaled nitric oxide, for that matter, sildenafil also is contraindicated. Both should not be given. Like obstructive TAPVR, we should not give sildenafil because it will cause pulmonary vasodilation, and the obstruction will suddenly become more overt because more blood is going to pulmonary circulation and there is a pulmonary venous obstruction. There is no exit to that blood. So everything gets obstructed into the pulmonary veins. Suddenly pulmonary venous pressure is further high. It may lead to the bleeding also. So is it little bit clearer now? Pulmonary artery hypertension can be secondary to pulmonary venous hypertension. Now the question comes, why the PPHN patient should have dysfunction? Okay, so it is always to start with right ventricular dysfunction. So what happens? The fetal circulation, there is a ductus arteriosus. Fetal life, right ventricle is able to take that. But for longer duration, it is not meant to take high pressure. Now, after birth, as soon as the first breath is taken, the pulmonary artery pressure should drop. But it has not dropped because of any mechanism. Your lung is a problem, or your ventricle, or there is a cardiac problem. So it has not dropped. So what will happen? It will sustain for some time, but then it will start with dysfunction. Once there is a right ventricular dysfunction, there is a shift of interventricular septum on the left side. And that will reduce the left-sided your cardiac output. And right ventricular dysfunction, no blood is going to pulmonary circulation, not much blood is coming to LA and LV. So that's why these patients may present with shock and hypotension. With shock, hypotension, lactic acidosis, desaturation, and metabolic acidosis at the peripheral circulation with the shift of interventricular septum, all these things will lead to secondary left ventricular dysfunction. So first, always it is a right ventricular dysfunction. Left ventricular dysfunction is secondary to your acidosis, shift of interventricular septum, or hypocalcemia and electrolyte imbalance. All these things will lead to secondary left ventricular dysfunction. For students, is it now a little bit clearer?
Yeah, so PPHN is always a complicated issue even after DM. So babies with PPHN are the most difficult babies to manage, and as you explained rightly, we always felt that dilating pulmonary vasculature is the only solution. But obviously, after discussion, we understand that it might be detrimental also in cases of left ventricular dysfunctions.
Yes.
Because of the back pressure and backflow, which leads to pulmonary congestion. Now, regarding overall the seminar, I feel that for a fellow presentation, it included a lot more of information, and so we had little time to discuss regarding the clinical case presentations. We can have less of theory and more of a case presentation in future. No, Nalini?
Yeah. Now we discuss some bits. These are the sessions, so that orientation sessions. And some after 2 to 2 session, we do a bedside discussion also. So that time, bedside discussion time, completely the fellow can present bedside a ventilated case. But
Yeah, because
few of
there
the,
is so much of
that,
information that it is difficult for the fellows to digest everything in 1 hour. Mm. Yeah, so Bhavya, so even so we focus primarily on the management of PPHN, but we need to understand that we need to manage a baby first and then PPHN. So whenever a baby is coming to you with severe respiratory distress, I think the principles of management remain same before we go specifically on INO and such kind of stuff. So even in the PPHN babies, I think the primary management is TABC, maintaining temperature, maintaining airway, breathing, circulation, maintaining sugars, minimizing noise, ventilating those babies with the most in the most gentler fashion, and then maintaining their blood pressure. Even in PPHN, also maintaining them in the normal range, not exceeding the normal range, whether it's an oxygenation, SpO2, or blood pressure. So that's the motive of story. And obviously, after that, you discuss beautifully regarding the management with INO and in extreme circumstances when there is a right ventricular dysfunction, as Madam has explained us and told us about the use of prostaglandins, keeping the ducts open. Yeah, very good.
so the discussion is going on, but I have to take few of the questions from the audience. So
Yeah, that's very important.
not many questions are there. So one question came as a INO was given for 4 days. So was methaglobin level done? So that's what we discuss probably whenever we routinely do ABG. So ABG time we can see the methemoglobin level, so that a routine monitoring we can do by default. So whenever the long term, more than 24 hours, now we are giving nitric, it is better to have a methemoglobin level. That's the question asked. No further answers probably. We have to monitor that, no option with us. But the question, one question I am seeing here, grading of PPHN based on tricuspid regurgitation. TRZ, one of the diagnostic parameter we always use in
Center of Culture and Arts में exhibition blooming
Sweta.
Yeah, hi. So in case that the pulmonary artery pressure in children is divided depending on the systemic arterial blood pressure. So if it is TRZ, gradient is more than your 2/3 of systemic blood pressure. So for example, your TRZ is your systemic BP is 60 and TRZ is coming anywhere more than 40, then it is severe pulmonary artery hypertension. But if you want to take the absolute number, it is mean pulmonary artery pressure more than 25 millimeters of mercury. But it doesn't hold true in children. So if it is more than 2/3 of systemic blood pressure, the RVSP, right ventricular pressure, or your TRZ, we should consider that as a severe pH. Then 1/3 to 2/3 is moderate pH. Less than that, it is mild.
So little bit
And
inputs from me.
obviously, if you don't
So,
find, I just want to add one more point. If you don't find your TR signal appropriately, that may happen sometimes. But if your ductus arteriosus is bidirectional shunt or it is right to left shunt, then please consider that as a severe pH.
we know TRZ, some fallacies are there always, and the calculation classically the way with including the pressure. For the book region for the people who write theory questions in the training, and we want to answer the question. The levels who asked, I don't know, maybe practicing somewhere, but if you will go to the book in a neonates, the level written pH below 32 or 30 is normal. Above 30 or 32 is the mild pH up to 45. Beyond 45 to 60 moderate pH, more than 60 TRZ, the severe pH. Classically, these findings we may not get during the 2D assessment because of the other shunts prevailing during the assessment. But if you can assess, you can measure, these are the few values you can remember. The way the OI values, Dr. Barbara told, the OI values are as per textbook, some values are there. When you can classify the TRZ, some values are there with its own fallacies. But you want to somewhere write an answer, these are the cutoffs for the newborn. But so you can say 32, 32 to 45, 45 to 60. So these are the cutoffs you can remember to answer. But assessment time, as we know, all of dynamic baby and a lot of fallacies will be there. And I sometimes underestimate the TRZ in presence of a severe PH, that the cardiologist, whenever assessment time, they holistically assess the ventricular dysfunction or the thing, just don't measure the TRZ many times. So question answer probably this much.
Can I just comment, Nalini sir?
Yeah, please.
Yeah. So couple of things over here is very nicely explained. And whatever the Nalini sir said, the pressures, assuming that the normal systolic function and normal systolic pressures. And the second thing is your right ventricular pressure. I don't know whether Dr. Shweta might have already explained. You are taking your TRZ as a proxy of your right pulmonary artery pressure, thinking that there is no obstruction to pulmonary blood flow, thinking that there is no shunt across the septum. So across the interventricular septum, if there is a VSD, there is a pulmonary arterial obstruction by stenosis or anything, it can't be a real proxy. And the most important thing I'm sure you would have already discussed is it's not just the TRZ, it is the entire dynamics. And bear in mind, it is a continuously changing parameter. Okay. And when you sample the TRZ and it's a three-dimensional flow, so as Dr. Shweta already mentioned, it is very important to get the sampling and the envelope of the TRZ right to get the right value. I stop it there, Nalini sir.
Yeah, fine. Right inputs. Then I will ask all the faculties to quickly to give inputs. One of the question came from student, when to use vasopressin. We talked about milrinone, we talked about inotropes, but question came here, when to give the vasopressin in PPHN cases. Maybe few people are using, so that's the question, but how to answer that, how to guide them. Mittal sir.
Yeah, so as we know that milrinone is not a specific pulmonary vasodilator. So whenever you are using milrinone, there is always a risk of hypotension. And in a baby who is already having a low blood pressure, if you need to use milrinone, you also need something which can maintain the blood pressure. Now, those are the drugs like adrenaline and vasopressin. Adrenaline at higher dose is also detrimental in PPHN. So in those scenarios, you use vasopressin in addition to milrinone to maintain your blood pressures in a systemic blood pressure in a normal range. Yeah, so we use sometimes vasopressin in addition to milrinone in severe PPHN when your blood pressure is on the lower side.
Yeah, but one need to be very careful about vasopressin in cases like, or any vasoconstrictor, I'll say. If there is LV dysfunction, try to be careful, extra careful in putting vasoconstrictors, because these
Yes,
are very critical cases. One of the drug here and there can make huge problem for the baby.
Yeah, rightly said. So we should always check left ventricular ejection fraction and left ventricular function before using any vasoconstrictor. That's very true. Next question, Lynn.
Probably the questions not many. The questions are asking the inotropes, other things we discussed. One question again I will ask to clarify. We discussed the RB dysfunction is dominant in PPHN, but if there is a concomitant left heart dysfunction is there, which is the preferred agent of inotropes to use? That's a question probably we discussed. Again, the question came. So Dr. Bijanand, Dr. Shweta, anybody can explain, when there is a concomitant left heart dysfunction, which is the preferred agent to use? We have a plethora of medication. Which one to start? Which one to use?
In presence of right and left ventricular dysfunction, still milrinone is a wonderful drug. It's a first-line therapy even in left ventricular dysfunction because it reduces SVR and it acts like an inotropy. So it's a preferred medicine if the cardiac or if the blood pressure is holding on. If child is not hypotensive, then still we should prefer milrinone therapy.
Totally agree with Dr. Shweta.
So probably we are not doing any harm if the blood pressure is stable. It's not very labile. We are not doing any harm by using milrinone, be it LV dysfunction, be it RB dysfunction. If we are not sure, but as the first agent we start, probably milrinone is perfectly probably fine. The question came sildenafil or milrinone first choice. There's the sildenafil in presence of RB dysfunction PPHN, definitely sildenafil. But I will one caution word I will say, if we are using nitric oxide, concomitant nitric oxide sildenafil not a great idea. We will weaning when the baby is stable. When baby is nitric, we are weaning. Baby is stable. We are using in the additional sildenafil to wean off the nitric that maybe when already stable. The initial phase when baby is critically hypoxemic, critically sick, and two pulmonary vasodilators which are antagonistic in action and it accentuate one of the pathways, CGMP pathway. That's not a right idea to use optimum sildenafil and optimum nitric oxide at 20 ppm. That's a caution. So FDA has specifically cautioned when you use nitric, probably the sildenafil is not a great idea. It's a weaning time, probably perfectly fine. So nitric milrinone combination, nitric dobutamine combination, but not nitric sildenafil combination. That's not a great idea. That's one caution. Second cautionary word I will say, if you are thinking your primary disease is septic shock, multi-organ dysfunction with PPHN, be careful for sildenafil. In the presence of sepsis, cardiac dysfunction, nitric may be a great option, and milrinone and dobutamine depending on your blood pressure. But sildenafil alone in a baby which has a myocardial involvement with a septic component, when they share the common pathway of CGMP pathway, so that's a little tricky situation. But in presence of frank sepsis, PPHN, be careful of using sildenafil. Regarding sildenafil, these are the two practice tips I want to share with students. So you can use, but you assess and monitor. That's the key.
Nalli sir, I have a question for, I want to ask Jai Kishan Mittal sir, Ashish sir. Sir, you guys try to always add sildenafil as you wean the nitric if they are not? Or
When we reach to 5 ppm situation,
yeah,
and we know that in a 24 hours we are going to take baby off nitric, that's
okay,
the time we start with the oral sildenafil, syrup sildenafil.
Okay, sir.
Yeah.
Jai Kishan sir?
No, we are not using sildenafil as a weaning
Yeah.
modality always, because even PPHNs, some PPHNs resolve with INO for a shorter duration of INO therapies, and they do not require a prolonged duration management with sildenafil. But as Dr. Ashish sir has said that if a baby needs prolonged duration of INO and we feel that the hypertension pH will be for longer duration, in those selective circumstances, we use sildenafil as a bridge therapy.
Agree,
I
sir.
understand the literature says that because of the prolonged use of nitric oxide, endogenous production is little bit blurred. So for tide over that period, that sildenafil is required.
Agis, I've seen both the practice. I just wanted to check with. If it is a very quick response to your nitric, not prolonged, and may not
It's all right, yeah.
Yeah. And if it's a prolonged, like in this case, if they're already on sildenafil, that's a different discussion. But a prolonged use, probably yes. Yeah, agree, sir. I just wanted to check how you
Dr.
guys.
Nalini, can I ask you about this sildenafil and nitric combination, because there is very commonly used in
Yes.
the peripheries. And what happens? Like what goes wrong? I understand it uses the same pathway.
No, sildenafil, nitric, because nitric oxide is not commonly available in many places. They start sildenafil probably after referring a higher center, we started using nitric oxide. So nitric oxide and sildenafil, what they say, they counter with each other. They are not. There are some classifications like bosentan nitric oxide. They may be agonist. They may be synergistic. So if I am using milrinone nitric, there are two. There is a systemic vasodilation. Plus pulmonary vasodilatation, because as we know, nitric oxide, very beautifully the picture is there, microselective and selective. So the pulmonary components address, the systemic component addressed by other agents, which is they synergistic to each other. But here both the pathway, CGMP pathway only. So if it stable baby may not happen any harm, but refractory hypertension needing escalation of treatment is a possibility when we use both optimally. That's the question. I'm using 20 ppm nitric and I'm full dose of 1.5 milligram to 3 milligram per completely 1.4 milligram to 3 milligram sildenafil. I'm using IV with infusion or 1 milligram per kg 8-hourly oral dose of sildenafil, which is optimum. I'm not talking both weaning. Weaning time they agree. Few of the trials they did rebound of nitric when it happens to 5 ppm to 1 ppm.
My question is that what goes wrong? What is the problem?
refractory hypotension. That's the issue.
Okay.
They say use both. You have to use a lot of inotropes, but there is a cardiac dysfunction induced. But you don't use sildenafil. You are using nitric. You are getting results. Why to use another agent which can harm the baby? That's the FDA licensing. Like FDA licensing till now in infancy, the sildenafil is not licensed at all. That's the only preferred agent for FDA is bosentan. But bosentan, we know the oral form, chronic form. Acute cases, we rescue with sildenafil. Plenty of experience in resource-limited country like India and Brazil. India and Brazil, the informations are enormous and plenty. We don't have a second doubt about sildenafil's utility. But when it comes to double agent, there is a clue. When in presence of sepsis, there is issue. Otherwise, that's perfectly fine to use alone sildenafil. Though maybe the FDA not licensed, but we are probably happy and we are using since years, last 20 years probably. Sildenafil is agent.
There are many questions in the chat box. We want to go through that, Dr. Nalini?
Second word of caution is whenever IV drug is available, we generally feel that the IV will be better than the oral. But that's not true with sildenafil as like ibuprofen. So even though IV sildenafil is available, the experience and whatever literature is available is with oral sildenafil. So do not tempt to replace oral sildenafil with IV sildenafil.
IV 1 point, I will say it here. IV sildenafil, when we are not giving 8 hourly or 6 hourly, we are giving infusion. There is the effect and side effects. Both are little controlled. In the oral form or the IV bolus forms, once we release the medication into the baby, there is no further control for 6 to 8 hours. That is one advantage of continuous IV infusion. You have a control on medications. You are using, you can decrease the dose, you can monitor the blood pressure, you can stop the treatment. If the response is poor, you can escalate with increasing dose. That's the beauty of IV. Efficacy-wise, they remain same. But when controlling the environment, the adverse effects, probably the IV is a better control. When you oral, you release the medications already gone into the body. Absorption already there. If only oral condition, when baby is already poor perfusion intestine, there are multiple inotropes required. And baby is already poorly perfused in the sucky state. That's maybe the oral agent, like any other medication, sildenafil absorption is poor, IV is better. But a stable perfused baby, the oral medication, IV medication, equal efficacious. Only people are preferring IV in intensive care situation because there is a well control if we are putting an IV in future. That's the only thing. Otherwise, one is better than others. There is no evidence one is better than other. So any further question? Can we take further questions? Probably, what duration is considered prolonged use of nitric? There is this question. I don't think specific answer. Ashish sir, do you want to take the what is prolonged? I don't know what is prolonged by definition.
No idea. No idea.
Because we know refractory definition is clear. If not responding by 6 hours, 4 to 6 hours, not responding by improvement in 10 PO2, whatever existing PO2 baseline, not improving after using 20 ppm standard dose, we can cause refractory or relatively less effective. But prolonged definition by time duration line, I'm not aware. Maybe some book or protocol, maybe anybody can contribute, but I'm not aware what is prolonged.
So we do not know the definition of prolonged, but generally speaking, these babies, the average duration or the mean duration of INO requirement in these babies is approximately 72 hours. So plus minus few hours. So if a baby is requiring INO, if it is difficult to wean from INO beyond 72 hours, so few baby might need some amount of INO support for days together. And those are the babies which probably have maldevelopment of pulmonary arteries because of the muscularization of arterioles or hypertrophy of musculature of small arterioles. Those are the babies who will require a prolonged duration of some kind of pulmonary vasodilator, and they are probably the candidates for a longer duration of sildenafil therapy.
Absolutely. So questions are not there many. We are going time already 9:40. 1 or 2 practice questions. We missed few things. I will ask I'll invite all the faculties to contribute. Whomsoever can take the questions. Any 1 or 2 questions per student might be. I will say when you are talking about pulmonary vasodilator, as per our basic physiological knowledge, we know oxygen is the most potent vasodilator. So don't forget about oxygenation. I am saying not to hyperoxygenate, but careful about oxygen. Give oxygen, then we talk about pulmonary vasodilators, because that's a message I want to give. But few questions. Any of the can say any of the faculties or the also can take questions. When the surfactant is helpful
कौन सी
in
गाड़ी है? आप तो बिल्कुल स्ट्रीमलाइन है. कहाँ पे खड़ी हो गया आज?
when the surfactant is useful, when the role of hydrocortisone, what is role of magnesium sulfate,
कहाँ पे था मेरे को बताइए, मैं भी देखता हूँ.
different medications lot of people use, but any of the faculties, this magnesium, role of magnesium, my role of, because all others we discuss, I'm not coming, role of hydrocortisone, when to use, role of sildenafil, role of surfactant, because we know surf it early in the early tide. That's the dialogue by Dr. Satyan. So if you want to use surfactant, surf it early.
आपको
Use it
परेशानी
early.
इसके लिए तो मैं माफी चाहता हूँ, पर मेरे को 1 मिनट बताइए. नहीं, पर मेरे को एक बार मेरे को समझाएंगे तो सही ना एक बार, तो बाकी मैं एक्शन तो ले पाऊँ. अभी जैसे आपने जैसे कहा था, तो हमने कोने की गाड़ियों पे तो वहां पे तो बंद ही कर दिया था अपन ने, ये जो वो लगवा के.
Hello, someone's mic is to be unmuted.
इनमें तो बिल्कुल नहीं थी आज.
Okay, please continue, sir. Assis sir, continue. I unmuted for a few seconds.
Yeah, basically, we do not have one-to-one thing that when to use sildenafil or when to use this milrinone or when to use you said magnesium sulfate and all that. See, in a resourceful setting where the availability of nitric is there, it is a drug of choice as a base pulmonary vasodilator because it is locally acting and it doesn't have any effect on the systemic pressures, which is very important thing when you talk about PPHN management. So if possible, priority would be nitric oxide. But in the cases where it is not available, then the options would be apart from the basic management, temperature control, control acidosis, minimal handling, no noise or light pollution, apart from making good asepsis, nutrition, all this will come in the front. And then if and baby friendly handling and all those things. If baby's PPHN is still not coming under control, then the treatment would be, if in absence of nitric, would be one of your choice. Maybe sildenafil, one of the vasodilator, maybe one of the milrinone, if your LV function is good. And then Maxsurf is one of the things which people have been using in past. But Maxsurf will require regular monitoring of magnesium levels. So again, if your lab is all right, then and then only you talk about magnesium, number one. Number two, magnesium is also going to cause systemic hypotension. So in that case, you are closely going to monitor systemic pressure because worsening of the systemic pressure is also going to cause worsening the PPHN. So these are the things which I'll be using with more caution and would try to get nitric as early as possible in those kind of situations.
So the last question, which may not be very, very relevant except in the few of the areas of India. So Dr. Sweta is very well experienced here on that context, PPHN, and Dr. Bijan also has seen challenging cases responding to that intervention, which is cheaper, which is safer. So any thought of thiamine, use of thiamine in the PPHN cases of subset of cases? I'm not saying all idiopathic PPHN will respond, but I will, through this discussion, I want to send some message. There is some subset of PPHN is there where this thiamine works. And probably Dr. Sweta and their group worked a lot. They have their own publication. We have our own publication in international publication of PPHN and thiamine. So Dr. Bijan and Dr. Sweta experience little, which are the candidates when I may think of to use.
Before that, Dr. Nalini, there is a question that if baby not responding to 20 ppm, then till what extent we can increase INO?
Yeah. Please, sir.
In the chat box, there is a question. So my answer would be that you go up to maximum 40, but going beyond 30, 40 will not cause any difference as per outcome is concerned. And I have never seen anyone going beyond 40. Maximum in my whole career, I've used is 25, 30. Never gone to that high level and never seen baby responding at 40 ppm.
Fully agree, sir, with you. 20 ppm for not responding, we have done occasionally towards 30. The book previous 40, they we never gone to 40. But as per experience, you are right, perfectly right. If not responding to 20, may not respond to 30. We may transiently increase to 30 minutes to check is it responding little supratherapeutic dose. But actually, if not responding in 20, usually they don't respond in 30. That's the case we have seen many a times.
And the second question is there any ideal BP to be kept in PPHN? There is no ideal number, but at least it need to be should be more than pulmonary pressure. You know, look at the tricuspid jet, look at the right atrial pressure, and your systemic pressure will be more than that. That is what we can say. So your cardiologist or functional echo, you look at that number of the right atrial pressure, and then your systolic pressure, systolic systemic pressure should be above that number.
Like previously, we were talking about hyperventilation, respiratory alkalosis. Absolutely no. We are talking about supraphysiological blood pressure. That's also absolutely no. If we are maintaining the systemic blood pressure as equal as pH, probably perfectly fine to maintain the perfusion. These are two practice stages. No high oxygen target, no low carbon dioxide target, no high blood pressure target. Blood pressure is physiological as possible, not very high. So these are the messages probably currently.
Now it's your question.
Absolutely.
So,
I mean, it's a bear in mind, you want to open up the pulmonary artery. You don't want to constrict the systemic arteries. That is the idea. If you understand that basic physiology, you might get a better number, but you might not get the better oxygenation. I agree with Ashish sir and also Nalli sir.
Yep.
Dr. Sweta was coming to picture. Thiamine is not uniform. Just a word of caution. We deal newborn and we'll deal with infant up to 1 or 2 months old also in PPHN. So these are the cases where we will look for. And Dr. Sweta.
Yeah, absolutely right. So they are not mostly newborn. They won't be soon after the birth. They are exclusively breastfed mother who are eating predominantly rice food, and that too the food that is the rice which is always washed. So the baby who is exclusively breastfed and mother feed dependent, and where the mother is a subset of thiamine deficiency, they present with wet beriberi. And I want to tell you, it's not rare entity. It's not only in books. It does exist, and it presents with just severe pulmonary artery hypertension. And if we don't correct it on time, we have seen them going into renal failure, presenting with shock, requiring ventilation. They won't respond to your sildenafil, INO, anything, because mechanism is different. It's a high cardiac output failure patient. So clinically, how to identify a background of a mother who is predominantly eating only rice, which she is washing multiple times, and the baby is exclusively breastfed. There would be a history of weak cry, little bit floppish kind of baby with acute onset history since last 4-5 days. Baby is not doing well, and echo would show that there is a severe pH. Clinically, one very important finding I would tell you, which I learned from Dr. Somaraju, who is a cardiologist, all PH patient, they would have cold clammy extremities predominantly. But here, if you palpate them, they would have the bounding pulses, warm extremities, because I said it's a high cardiac output failure. So then they are thiamine responsive. So you just give 1 dose of 10 mg per kg of IV thiamine, intramuscular thiamine, or nowadays orally also it is available. It comes with the name of Benalgesic, the commercial available name. 1 tablet is 100 mg of vitamin B1. And within half an hour, the echo would show it's a normal PA pressures. We have ample of cases because this part of the country, the predominant feed, the food that the mothers take is the rice food. So it does exist. I want to tell you, it really exists. So please give them the shot.
How come they become thiamine deficient, madam?
How would they?
How would they become thiamine deficient?
The mothers are thiamine deficient.
Okay.
The mothers, we did a study actually where the children, the infants presented with severe pH. So we took thiamine levels of mother and child both before giving thiamine, and we found that the mothers were severely thiamine deficient, but they were not symptomatic.
And because of what? Why?
Yeah, they are partially asymptomatic, maybe because of the demand, and it's just vitamin B1, which is a water-soluble vitamin, which requirement might be high in an infant than in the adult. So these differences are there. So the infants would present with the wet.
My question is why mother will become thiamine deficient?
I'll come to pictures.
The rice diet. She would eat 3 times only rice, and which would be washed multiple times. And they have a habit of cooking the rice in a large quantity of water. And once it is partially cooked, they throw away that water also.
Interesting.
So,
Thank you.
yeah.
Point in the country, whole country, it is not common, but for all
Yeah.
country, all over the country, the trainees are attending. So I will say Himachal Pradesh, Kashmir, Telangana, Andhra Pradesh,
Andhra Pradesh.
And a few of the districts of Karnataka and northeast state like Mizoram and other places. These are well documented cases reported across this part of the country, where the typical practice of an antenatal mother taking triple washed or double washed white rice after cleaning the coating completely. So that induces a thiamine deficiency. If somebody is a mixed diet intake, roti, wheat, and other millets, then probably thiamine deficiency won't be there. Predominant light taker, and these are the few: Kashmir, Himachal Pradesh, some part of the Himachal Pradesh, and coming to the south zone, these 3 states, and northeast again 2 states. So these are the few states where the dominant rice takers, white rice takers, this deficiency we found out. And for our sake, I'll say the presentation, whatever cases we presented and published, that the presentation started 6 weeks typically. So few days after deficient mother giving breastfeeding for a few days, 6 weeks after the stock is over from the baby, and baby is completely dependent on mother milk, exclusive breastfeeding babies, those presented 6 weeks to 8 weeks. Even we started nitric, typical presentation will be, there's the way Dr. Sweta informed: high output failure, warm periphery, voice change or hypotonia. But one interesting finding, lactate was uniformly high in all the babies. Once we given 1 dose of thiamine, the lactate started decreasing, and nitric came out within 6 hours to 8 hours. So these are a typical we have seen in the babies of thiamine deficiency disease PPHN. But it has limited to few of the patches of India. And after completing the infant presentation, I followed up last 2 years. We got 5 cases. We are presenting those in neonatal. Neonatal presentation, hardly 1 or 2 cases world over observed. But when we are aware, we are doing the thiamine level of mother and baby diets. Now we identified 5 babies of PPHN which did not respond to nitric and sildenafil. But once we put the loading dose, they started responding thiamine dose, 50 milligram of thiamine IV, and started responding over 4 hours. So that response happened dramatic. But this is a subset of people who are with Dr. Sweta well described, antenatal mother, exclusively rice taker, white rice, double or triple washed, and they continue taking postpartum time also. Those are the babies who suffer with thiamine deficiency.
In Telangana, Andhra, it has changed a little bit now, but it's traditionally what they would do is they take out the ganji, and then give the food, and with that they give some spices, mirchi deke, especially the lactating mother. So because they don't want anything heavy, they think it is a light food that she digests well. And I would say one practice point here. I think Dr. Shweta and Dr. Nalini sir can I mean, you tell me whether it is fair to say that in a refractory pulmonary hypertension where you have done maximum, and we did this before as well, there is no harm giving IV thiamine after taking the levels. So if you are losing the battle, there is no harm, I would say. And I mean, Dr. Shweta and Dr. Nalinikanth can comment.
I totally agree with Vijayanand sir that loading dose of thiamine 10 mg per kg, where the things are not fitting in place, it's not responsive, it's no harm. And even though taking levels, and very few labs are actually doing thiamine levels, and that too with accuracy. So even if that facility is not there, supporting this babies with thiamine level is very, very important. Even all our patients where they come with idiopathic pH, before starting sildenafil, we give them a shot of thiamine, and it also works at mitochondrial level. So it works, it is always helpful. I totally agree on that. Even if we cannot take the level, it's worth giving a dose of thiamine.
How much is the dose?
It's 10 mg per kg.
Okay. Intravascularly?
Yeah, we can give intravascular, we can give intramuscular. When even IV was not available, few babies we have given oral. Even those where we have responded, within few hours, we would see that peer pressure is normal. So it works
Very
wonderfully.
interesting. Great.
Yeah. Maybe
Okay, so
in
again, Nalin.
some of the session we can show in comparison this babies, the echocardiogram.
So time limiting, interesting discussion. Many of the learning points today very well presented. The case very well presented, very well managed. A HFO baby who are in peripheral hospital coming to referring time, taking the challenge, transporting and managing, commendable. I will definitely appreciate the managing the baby, and recovery of the baby happened so well. And the examination time when he was examination finding, when we were listening, we listen like a normal newborn baby. Systemic cardiac examination, respiratory, CNS, everything absolutely normal. Such a hypoxemic baby. That's a commendable job. Presentation was very good. Theoretically thing, I suggest the student during presentation, keep limited to 3 or 4 slides only, so that just little flavor to add, but discussion should happen more and more. But well discussed today, all the faculty's inputs are great. So with one message from all the faculty, you can close the session. Each one I'll invite with Dr. Mittal sir, Dr. Ashish sir,
So
Vijanan, one message.
yeah, so my message is again the same, back to the basics. So even if it is PPHN at the fellowship level, I think the baby should be treated in totality, and maintaining the vitals, maintaining sugar, calcium, temperature, and oxygenation is as important as managing PPHN per se, because these things actually helps in pulmonary vasodilatation. And we also have discussed that stress, pain, temperature, hyperthermia, hypothermia, they all are contributing factor to aggravate PPHN. So those should be managed first before moving to the INO stuff.
Yeah, try to answer unexplained oxygen requirement and think of a differential diagnosis. It can be PPHN, it can be anything under the sky. So unexplained oxygen requirement is to be answered and justified.
I would say the moment, you diagnose PPHN, either clinically or echocardiography. Nowadays, echocardiography availability has increased even the district places. Think about why PPHN, why this happened. We have seen people starting sildenafil without helping the baby where there are lungs which are not quite good. So that doesn't help. So ask the question why. I agree with Ashish sir and also Jai Kishan sir. Optimize everything, and nitric and other things only add provided you optimize the other care. So it's a supplement but not a substitute but the rest of the care. Yeah, I'll stop it there.
So Dr. Sweta,
Yeah, I totally agree with all my fellow faculties. Treat baby as a whole and think as a differential diagnosis. If there is any cardiac problem, we need to treat that. And as Dr. Vijayan sir has said that they are the INO sildenafil, they come last, treat probably the cause. So I agree with everybody, same.
Perfectly fine, well said. All the faculties probably pass the message, the key messages. With the closing message, I will say, whatever treatment and protocol we follow, probably the monitoring is the key to get the best result. Unless we are bedside, we are continuously monitoring, the optimum result never possible. So don't leave sick babies. Stand by bedside, monitor all the things, get your set target right, then probably we will get the result, whatever the protocol we follow. That's the message for all the cases. Similar here for a sick baby. With that, I am closing, thanking Dr. Bhaga and Dr. Ashish Mehta sir, both the team, to present the case, such a challenging case today. With that, I'm closing the session today. Thank you all the faculties.
Thank you very much.
See for the
Thank you,
again
everybody.
in the next.
Thank you.
Thank you all. Thank you, Dr. Sweta. Thank you, Dr. Vijanan.
Thank you.
Dr. Mittal.
Thanks, Xavier.
Thank you,
Thank you.
To prepare the
Pleasure
discussion
joining
very
here.
short notice. Thank you.
Thank you all.